So the next in the group of glomerular disorders, we are going to learn regarding membranous nephropathy. Membranous nephropathy. You can also call it by the name membranous glomerulonephritis. Membranous glomerulonephritis. Okay. So let me begin by telling you one point that like your minimal change disease and FSGS, this disorder, membranous nephropathy, is also a podocytopathy. This is also a podocytopathy. Okay, a disorder affecting the podocytes. Okay, so that you can say the minimal change disease, FSGS, as well as your membranous nephropathy are all podocytopathies. Okay, clear. So let's try to see more details about membranous nephropathy. See, this disorder, the age group of presentation, okay, the age group of presentation is around 30 to 50 years. 30 to 50 years, and males are more affected than females in a 2:1 ratio. Okay. Now one point that you have got to know is that though the classical age group of presentation is 30 to 50 years, membranous nephropathy can also present in the elderly, and keep in your mind that the most common, okay, the most common cause of nephrotic syndrome in elderly, okay, nephrotic syndrome in elderly, okay, in the elderly age group, okay, so that is going to be your membranous nephropathy, okay, membranous nephropathy. Now this is very important because we have already learned regarding the most common cause of nephrotic syndrome in children being the minimal change disease, in adults being the FSGS, and when it comes to elderly above 60 years, so that is membranous nephropathy. Okay, very important. All right. Okay. So now moving on to the finer aspect of this disorder, membranous nephropathy. Please understand that this membranous nephropathy can be classified into a primary membranous nephropathy as well as a secondary membranous nephropathy. Primary and secondary. So regarding primary membranous nephropathy, see, almost 70% cases of primary membranous nephropathy is because of antibodies to phospholipase A2 receptor. Okay, 70% is because of antibodies to phospholipase A2 receptor. You may also have antibodies to thrombospondin as well. Some cases are because of antibodies to thrombospondin. But for your exam, this one is very important, anti-PLA2 receptor. Okay, and this can be asked as a question also. Very important causes of primary membranous nephropathy. Clear? Okay. Now coming to the group of secondary membranous nephropathy, that is membranous nephropathy occurring secondary to some other conditions. This again is very important. You may be asked in your exam regarding the secondary causes of membranous nephropathy. So let's see what are the causes of secondary membranous nephropathy. Secondary membranous nephropathy, first of all, it may be because of certain infections, okay, because of certain infections, and among the infections, the ones which are implicated in membranous nephropathy, you have your hepatitis B, hepatitis C, hepatitis C. Remember when I discussed regarding FSGS also, I told you hepatitis B can cause FSGS. Here also hepatitis B can cause membranous nephropathy, but not just hepatitis B, hepatitis C also can produce. Then you can have syphilis, syphilis, schistosomiasis, then you can have malaria, leprosy. Okay, so all these are infections which are known to produce a secondary membranous nephropathy. Now, other than infections, you may also have malignancies. Okay, malignancies. And malignancies, the solid organ malignancies predominantly, like your CA breast, your colon, stomach, lung, okay, even neuroblastoma also, neuroblastoma. So these are the malignancies that may be associated with membranous nephropathy. Then you can have drugs associated with membranous nephropathy. Drugs associated with membranous nephropathy. And what are the drugs associated with membranous nephropathy? You can have gold, mercury, D-penicillamine, and NSAIDs. Now, something that is very interesting here is that you see here gold, correct? Gold. Remember, when we discussed regarding minimal change disease also, I had mentioned about gold. But at that time itself, I told you that gold predominantly produces a membranous nephropathy, but it can also produce a minimal change disease. Okay. And when it comes to NSAIDs, remember NSAIDs can predominantly cause minimal change disease, but can also cause membranous nephropathy. So you have got to keep in that mind that point. Okay, all right. So drugs causing membranous nephropathy. And then you may have autoimmune disorders associated with membranous nephropathy. And what are the autoimmune disorders associated? You can have a Hashimoto thyroiditis, SLE, rheumatoid arthritis, Sjogren's syndrome, sarcoidosis, and also IgG4 related disorders. Okay. So this is the list of conditions that can produce a secondary membranous nephropathy. This is very, very important. It has been asked before also. You have this table from Harrison, okay, showing the primary membranous glomerulonephritis as well as the secondary membranous glomerulonephritis. All points we have discussed regarding infections, malignancies, drugs, autoimmune conditions. And there are certain systemic disorders like Fanconi's syndrome, sickle cell anemia, diabetes, all having association with membranous nephropathy. But the causes, the etiologies that we have discussed are the ones most important for your exams. So you must be very, very clear regarding that. All right. So we have learned regarding the primary and secondary membranous nephropathy. Now let's try to see, okay, what exactly happens in case of a membranous nephropathy. Okay, the pathology wise, because we have seen primary membranous nephropathy, there is a antibodies against phospholipase A2 receptor, and that is actually present in the podocytes. So the antibody attacks the podocytes. So I'll just show you a pictorial representation, and see, you can see here in the image that it is proceeding through various stages. Stage 1, 2, 3, 4. Okay. These are the stages through which membranous nephropathy progresses. In fact, there is a stage 5 also. But these 4 are the most important stage. It is just the stage 4 that is continuing to the stage 5, the terminal stage. But understand that the pathology in case of your membranous nephropathy is characterized by subepithelial deposits. Okay, subepithelial deposits. So the immune complex deposits are located in the subepithelial region. Are you seeing the arrow pointing to the deposits which are depicted in black color? Yes. So you are seeing that they are all located beneath the podocytes, okay, subepithelial, all right. Now what happens is that as the disease progresses, it goes to stage 2. And what do you see here? Now I want you to be very careful. See, are you able to appreciate, okay, that the basement membrane, okay, in the stage 2, the basement membrane sends out certain projections in between these immune complex deposits. There are certain projections. Okay, I'll just take this color in a while so that you can appreciate it better. But now just observe wherever I have marked these projections. Now just see them. Are you able to clearly see the projections in between the basement membrane, in between the immune complexes? So will you agree with me that when I say there are certain spikes of the basement membrane in between the immune complex deposits? Agree with me? Yes. So that is what you are seeing here, spike-like projections of the basement membrane between the immune complex deposits in stage 2. And when it comes to stage 3, it is almost like the immune complex deposits are inside the basement membrane. Okay, it's almost like intramembranous deposits, and you can see the basement membrane almost covering the immune complex deposits in stage 3. Yes. And when it comes to stage 4, something that is very obvious, okay, which has started in stage 3, but the most striking feature of stage 4 is the increase in the basement membrane, glomerular basement membrane thickness. The GBM has become very, very thick. Are you able to see this? Okay, see the thickness here compared to stage 1. I want you to make a comparison of the thickness of the glomerular basement membrane in stage 1 versus stage 4. So it is very obvious that in the pathology of the membranous nephropathy, as the disease progresses, remember it is a membranous nephropathy, so as the disease progresses, the glomerular basement membrane becomes very thick, okay. And the immune complex deposits, you know, they are appreciated as lucencies here. Yes, they are appreciated as lucencies. Okay. All right. So anyway, it is a very, very thick glomerular basement membrane. So that is how the pathology progresses in case of membranous nephropathy. Okay. Very clear. And sometimes, you know, as a question, you might get this one. The spikes of the basement membrane, it is seen in which condition? Membranous nephropathy. Okay, so we have understood that. Next, after having understood the pathology, let's move on to the clinical features. Now, since this particular disorder, membranous nephropathy, is a podocytopathy, goes without saying that the clinical presentation of this disorder is with nephrotic syndrome. Okay, is with nephrotic syndrome. Okay, and see, nephrotic syndrome in case of a membranous nephropathy is quite distinct from say a minimal change disease, in that the nephrotic syndrome in case of your the membranous nephropathy, it will be having a non-selective proteinuria. Okay, remember in minimal change disease you had a selective proteinuria. Selectively albumin was being excreted in the urine, but this is actually a nephrotic syndrome with a non-selective proteinuria. Okay, so I'm not going into too much of details of nephrotic syndrome features, which we have already discussed in the module on clinical presentations of glomerular disorders. Okay, and in addition to this, there are certain points that you should know, that the patient may also have hematuria. Hypertension. Hematuria is mainly a microscopic hematuria, hypertension, and increased serum creatinine. See, at this point, if you ask me this question, classically nephrotic syndrome is associated with a normal BP. Yes, you are right, but that is actually for mainly the minimal change disease. But this disorder, like a membranous nephropathy, may have associated hematuria, hypertension, and serum creatinine as associated features, which is very important. Okay, And another point that you have got to know is that this particular membranous nephropathy among all the glomerular disorders has the highest propensity, okay, highest propensity for thrombosis. Highest propensity for thrombosis. That is, patients with membranous nephropathy may develop, say, a venous thrombosis, maybe a cerebral venous sinus thrombosis, a renal vein thrombosis, may develop a pulmonary embolism. So all in all, this is one disorder, membranous nephropathy. Though all glomerular disorders which have significant proteinuria are associated with an increased risk of thrombosis, but this disorder has the highest risk among all the disorders, okay, which is very, very important, has been asked multiple times, okay, this particular question. And another point that you have got to know regarding membranous nephropathy is that, see, 1/3 cases of membranous nephropathy will have a spontaneous remission, okay, 1/3 cases will have spontaneous remission. And then another 1/3 cases, another 1/3 case will be having a relapsing nephrotic syndrome. 1/3 cases will be having a presentation of a relapsing nephrotic syndrome. And another 1/3 cases, okay, will progress on to develop a chronic kidney disease, okay, chronic kidney disease. Okay, that is the natural course of membranous nephropathy. So you have got to keep in your mind that point also, okay. All right, so clinical presentation is also very, very clear to you. All right, so the common clinical scenario you might get in your exam may be a elderly patient presenting with say features of nephrotic syndrome, and they might be asking you what is the most likely cause. This is going to be a membranous nephropathy, or maybe what is the underlying cause. You know, it is likely to be a malignancy. So they may ask questions with respect to your secondary membranous nephropathy. You can expect that also. Now suppose you go for biopsy in this patient. Okay, suppose you are going for biopsy in this patient. What are you going to see? First of all, you know, when you go for the biopsy in the light microscopy, tell me what are you going to see? See, in the light microscopy, the picture I will show you. See, the only striking point that you are going to see in the light microscopy is that the glomerular basement membrane thickness would be, you know, increased. Okay, you will not have any increase in the cellularity, no increase in the mesangium. All what you can observe, and that too it sometimes requires careful observation, is the increased thickness of the glomerular basement membrane. Okay, increased GBM thickness. Okay, so I hope you know, you can see this. It is difficult to make out if it is a basement membrane thickness or an increase in the thickness of the capillary endothelium, but still, you know, it is quite obvious that the region involving the capillaries as well as the basement membrane is more thickened. That is what you can make out, yes, in the images. Okay, so increased glomerular basement membrane thickness, that is the light microscopic finding. Okay, and when you go for a immunofluorescence, okay, in the immunofluorescence microscopy, tell me what is going to be the finding. Can you tell me? There will be diffuse granular deposits of IgG and C3. Okay, diffuse granular deposits of IgG and C3. In case of your FSGS, you may get some IgM. Okay, but here it is the IgG and C3 which is deposited in a diffuse granular manner. Okay, that is what you get in case of immunofluorescence microscopy. And what about electron microscopy? What about electron microscopy in case of your membranous nephropathy? I'll just show you an image. Okay, so as I told you before when we discussed that simple diagram, what you are going to see, you are seeing certain straight arrows here as well as certain curved arrows. The straight arrows are actually showing the immune complex deposits, and the curved arrows are in fact the spikes that I was talking about. Okay, in between the immune complexes you can have all these spikes of your basement membrane projecting in between. That is what you are going to see. Okay, especially in the stage 2 of your membranous nephropathy. So that is probably what you are going to appreciate in the electron microscopy. All right. So that is also very clear. So you are clear with the biopsy findings in case of membranous nephropathy. All right. Okay. So finally, let's go to the treatment of membranous nephropathy. So you have primary membranous nephropathy and secondary membranous nephropathy. So just like in secondary FSGS, the secondary causes are treated, you have got to treat the condition. Plus you may go for agents like say your AC inhibitors. Okay, AC inhibitors will help you not just for your hypertension, but also it will help to retard the proteinuria. So if necessary, you can go for AC inhibitors as well as statins in case of your hypercholesterolemia, and definitive management for the secondary FSGS. So it is for primary membranous nephropathy, that you would want immunosuppression. Okay, that you would want immunosuppression. And what is that you will give? You will give steroids plus cyclophosphamide. Steroids plus cyclophosphamide is given. Okay, often you have to give a combination. And you also have other agents that can be used, a calcineurin inhibitor like cyclosporin. You can also try mycophenolate mofetil, as well as you can go for rituximab. So these are the agents that can be tried, but best efficacy is with the combination of steroids and cyclophosphamide, which is used for the treatment of a primary membranous nephropathy. Okay, so just summing up, remember this is the most common cause of a nephrotic syndrome in the elderly, and any case of membranous nephropathy, do work up for the secondary causes. Very, very important, because remember when I mentioned regarding FSGS also, I told you the importance of identifying a secondary cause is because secondary cause you will not go for the immunosuppression, correct? So it is the primary cause that you will go for the immunosuppression here, and all the other points that I have mentioned regarding the biopsy findings, clinical features, increased risk of thrombosis, all are favorite questions for your exam. Okay.